basically approaching a patient who has a strong family history of heart attack. Often we see patients who have a strong family history of heart attack. So for example, father, mother with early heart disease. And the patient is often concerned about their own risk. And the question becomes, what do we do when we see these kind of patients? Why does somebody develop early heart attack? What we've worked on is trying to understand the specific genetic reasons why somebody might develop heart attack early in life. When you think about people who have heart attack at a young age, there are three major reasons one could get there. One is a mutation in a single gene that strongly predisposes the person to heart attack. That's so-called the monogenic model. Another way is mutations in many genes that in aggregate actually puts the person at risk for early heart attack. That's so-called polygenic model. And the third is actually lifestyle, so smoking, weight, and so forth. What we've done over the last 10 years or so is try to figure out for the genetic component, to what extent does early heart attack due to a mutation in a single gene that has a large effect, or polymorphisms in many genes that additively actually lead to early heart attack. And we've developed answers for both of those. So it turns out if you look at the single gene issue, it's really just one major gene that predisposes patients to heart attack. And that is a gene called LDL receptor. And here the mutations increase LDL cholesterol markedly, and individuals have heart attack at a young age. And this runs in families. Now, unfortunately, this is only responsible for about 2% of all early heart attacks. So suggesting there's still a lot more we need to learn. But for that 2% of individuals, knowing this information can really help that patient and also their family. We also have looked at the polygenic idea that the additive effect of multiple mutations may actually put people at risk. We've identified about 50 different spots in the human genome sequence that each contribute to risk of heart attack. And individuals who carry a lot of these variations that are increasing risk, they in aggregate can be at markedly higher risk, maybe 2-3-fold higher risk based on this genetic profile. The way we're approaching patients right now who have a strong family history is we can consider thinking about whether there's a single gene problem in that person, in that family, or is it the additive effect of these multiple polymorphisms? I think family history is often the starting point. So basically, if, as you said, if your mother, father, brother, sister had early heart disease, that puts you at about 2 to 3-fold increased risk. Now, of course, the challenge is, as you said, many patients may not know that, or they don't have that family history, but they still may be at risk. And this is really an open question as to what extent should we be evaluating somebody's genetic profile early in life to try to understand their risk. And we actually think that if you look at these 50 polymorphisms we've identified for heart attack, and you're able to test individuals early in life for these 50 polymorphisms, we can identify about 20% of the population that's about 2-fold increased risk for heart disease compared to everybody else. And that's actually a pretty important piece of information, because you could, with that knowledge, we could focus lifestyle interventions on those individuals, really encourage them to be healthier in terms of their diet, their physical activity, their weight. And you could potentially consider preventive medicines early in life. We have 2 medicines that have been proven to reduce the risk of a first heart attack, only 2, and that's aspirin and statin medications to lower LDL cholesterol. An open question is, who should be given these medicines early in life to prevent a heart attack? Because heart attack is the result of many years of silent problem in the artery, and then after several decades, at one time point, you develop a heart attack. So there's a long period where there's potentially an opportunity to intervene and prevent. And we think that the people who are identified as high genetic risk, maybe the subset of individuals should be given therapies, both lifestyle and potentially medicines early in life to reduce risk? The answer is no right now. Meaning that basically it's still in a research phase, that though we and others have robustly related these 50 polymorphisms to risk of disease, future risk of disease, and you can now do gene sequencing to find the single mutations that put people at very high risk, it's not routinely being used in clinical practice. And there are a number of reasons for that, but typically it has to do with reimbursement for these tests. And for the test to be reimbursed, insurers require that there's definitive evidence that knowing this information will actually help patients. And that's kind of where we are in the research field right now. You would really need to show that with this piece of information, I can do something, intervene in patients, and that intervention makes a difference. So in these scientific sessions, there was actually a pilot study done by a colleague at Mayo Clinic, Dr. Kulo, who presented this idea of disclosing the genetic information in a subset of individuals, not disclosing in another subset, and seeing if a person who is at cardiovascular risk and told that they were high genetic risk, would they actually be more adherent to medicines or lifestyle factors. And it turned out they were. That actually they were more likely to stay on statin medications to lower LDL cholesterol if they were told they were high genetic risk. So that's the kind of information that I think over time, other studies that show the same kind of thing could help convince insurers that this is a test that's worth having available. I think what it means is that we're going to be able to routinely incorporate this information into clinical practice. So just like when you go to your doctor and you get your cholesterol profile measured or you get your blood pressure checked, you may, along with that, in the blood, you can actually check for these 50 polymorphisms. The challenge, and I think the reason to think about genetics here is, again, this idea that heart disease, the blockage in the heart arteries, happens in your 20s, 30s, 40s, slow buildup over decades. And here with genetics, you have an opportunity to potentially identify the group of individuals who are more likely to develop that over time. And you can do this measurement early in life. The genetic stays fixed, it doesn't change. You only have to do it once, and it can potentially really impact the way we approach patients.